Hello, my name is Matthew Goldblatt, and today I will be talking about absorbable, synthetic, and biologic mesh when I prefer to use these. These are my disclosures. But the most important disclosure I need to make about today's talk is that there are no FDA-approved products for the use in hernia repair that have the indication for any level of contamination. So therefore, permanent mesh, absorbable mesh, and biologic mesh are only indicated in CDC Class 1 or clean wounds. So all discussions in this presentation of the use of any of these materials in cases with any degree of contamination will be considered off-label use. So some objectives that I put down for a ventral hernia repair. Primarily, you want to prevent the hernia contents from protruding through the hernia orifice. And in the case of a fistula, you would like to reestablish GI continuity. Would like to provide a durable repair with a low recurrence rate, perform the procedure safely with minimal patient morbidity, reduce postoperative wound complications and long-term infections, and then reconstruct a functional dynamic abdominal wall. Now, not all of these are attainable in the same operation, but the goal in sort of the ideal hernia repair would be to attain all of these. And in many operations, such as this one, a nice simple umbilical hernia, we should be able to take care of all this. Most of the time, we wouldn't even reinforce this with any material. We would just sew this closed primarily. And in contrast, we have this patient who has had months of TPN, wound cares, split thickness skin grafts. He's got a multiple intercutaneous fistula. He's on steroids, etc. So this is a much different situation than just a straightforward ventral hernia. So in that situation, and in the majority of larger ventral and incisional hernias, we would typically want to use a reinforcing material. And so, in my opinion, an ideal material would have some of these characteristics. First, it would be strong. It would be both immediately strong out of the box and durably strong for a certain amount of time until healing was complete. We'd like it to be resistant to infection. Again, none of the materials are indicated for this type of use, but as an off-label use, we would like to use some of these materials in the contaminated fields. If it's going to be placed inside the peritoneal cavity, we'd like there to be an anti-adhesion barrier, or the material itself is resistant to adhesions and therefore fistulas as well. We'd like it to be easy to use, so you don't have a whole lot of back table prep. And we'd like it to not have any systemic inflammatory response. A local inflammatory response is needed, and I'll show you slides of this coming up. But a systemic inflammatory response where the patient starts to look sick is more than necessary. And we'd like it to be cost effective. Much of these materials are very expensive to either make or to develop, and so they're typically more expensive than at least the absorbable and the biologics are more expensive than a permanent mesh, but we'd like them to be as cost effective as possible. So when looking at mesh options, we have multiple permanent mesh options. They can be either macroporous or microporous. They have coatings, or some are not coated. They can be light, medium, and heavyweight, depending on the density of the material. And the three most common polymers that are used today are polypropylene, polyester, and polytetrafluoroethylene, or PTFE. That's not the talk or the subject of this talk, but I will talk about the biologics, both animal and human, as well as bioabsorbable. I'm not going to talk about some of the newer hybrid products that combine the permanent and the biologics or absorbable. Before I go into the absorbable and the biologics, I want to just talk briefly about the use of synthetic mesh in contaminated ventral hernias. And this is a well-done study by some very well-known hernia surgeons looking at the use of permanent synthetic mesh in contaminated fields. And they followed these patients on average for about almost a year, 10.8 months. They had some surgical site infections, as one might expect, about 7% in the class 2 wounds and about 19% in the class 3 wounds. Unfortunately, they did have to remove the mesh in 4 of the patients and had to reoperate in 12 of the patients. So prior to studies like this, many people thought that using permanent mesh in a contaminated field would have a much higher rate of failure. And so that's the success. The downside is that if you're one of those 4 patients or 12 patients, maybe you had some extra surgery and extra problems that may have been avoidable if there were a different material out there. So what are some of the other materials out there? Well, biologic materials have been around essentially longer than the absorbable materials, at least for the use in durable hernia repairs. And this is a landmark study done by Mike Rosen, looking at 128 of his patients in clean, contaminated, and contaminated fields. Very large, complex patients with excellent follow-up of almost 2 years. And in this situation, there were unfortunately 31% recurrences, which may seem like a high number. However, in some of the worst hernias, this is actually quite good results. The most well-known study looking at biologic meshes is the RICH study, sponsored by LifeCell at the time, and they were able to see that in contaminated fields, they found a 28% overall recurrence rate at 2 years. It's important to note, and if you look down here, that when there is when they bridge the material, so no fascial closure, they have a 44% recurrence rate. And I think now, knowing what we know, this number is probably unacceptably high and would continue to go up even after 2 years. However, when they are able to close the fascia, they get a 23% recurrence rate. So continuing to improve. More and more of these patients were getting retrorectus hernia repairs. So again, placement of the material as well as the material itself seems to make a difference. So what are some of the problems with biologics? Well, first is that they typically have a greater cost than certainly permanent mesh and even the absorbable mesh out there. They do require some sort of back table prep, usually just a quick wash, which is an improvement from the days when they had to be rehydrated or defrosted. But they do come from animal and human tissues, and that can be concerning to some patients. They used to have limited size, but now they basically come in much larger sizes, so that's not as much of an issue. The issue is that all collagen, whether from an animal or from human, is cross-linked, and cross-linking is what stops it from breaking down. And because of that, there's a certain amount of encapsulation, and we're not sure the effect of cross-linking on ingrowth. So those are some of the concerns with the biologics. And so I'm going to talk a little bit now about the absorbable synthetic meshes, at least the most common ones that are on the market today. Tiger Matrix is a combination of 2 separate polymers, and one's a fast reabsorbing and one is a slow reabsorbing fiber. The fast reabsorbing takes about 4 months to completely resorb, and then the slow resorbing takes about 3 years to completely resorb. There's some limited studies out there looking at this in animal models and showing that at 24 months, the material is still present. That's the clear areas, and then there's collagen and inflammatory cells around it. Another material is Phasix, and that is a poly-4-hydroxybutyrate material, which is derived from an extract from E. coli bacteria that is polymerized and turned into a mesh. It is fully resorbable in approximately 18 months. And here at a year, you can see in an animal model that the mesh is present. There's some macrophages and surrounding host inflammatory response around it, as well as collagen formation around the material, which we'd want to see in a hernia repair. There's some clinical data in this study looks at clean fields with higher risk. I'm a part of this study. And if you look closely here, you can see at 12 months, the recurrence rate was 2%. As we continued to follow the patients, at 18 months, we had a 9% recurrence rate, and that number unfortunately continues to go up slightly as we look further out. And that's being presented at SAGES this year and should be published. Another study looking at the use of this material with some cases that are contaminated by Yuri Nowitzki shows that about 1/3 of these 25 patients were in a contaminated field. There was a recurrence in an onlay at a year, and a couple of patients with some surgical site infections, but no mesh removals. The third polymer I'll talk about is BioA, and that is very similar in structure to a Maxon suture. It's fully reabsorbed in 6 months. And the COBRA study was done as a multi-institutional single-arm study looking at 104 patients with either class 2 or class 3 wounds. 90% of these were placed in a retrorectus position, and all achieved primary closure. And the results of this, using Kaplan-Meier analysis, showed about a 17% recurrence rate at 2 years. But when you sort of subdivide those patients, those that were in the retrorectus position had a significantly lower recurrence rate of only 12.7%, showing that may be the best place to put any of these materials. I did a similar follow-on study in my own patients. And when we looked at our retrorectus patients, a lot of these were actually clean, but significant, certainly plenty of them were contaminated. We had an 8.1% recurrence rate at 22 months. The recurrence rate for the clean wounds was 8.2%, and the contaminated wounds was roughly 8.1%. So very similar results regardless of contamination, and none of the material had to be removed. So in conclusion, I want to wrap up with basically some simple algorithm for the off-label use of absorbable and biologic mesh in contaminated fields. The retrorectus placement and component separation is a great place and a great way to fix these. However, it does certainly burn some bridges. And so if there is a high risk for complications such as leak, intra-abdominal abscess, then a primary closure would be reasonable. A bridge with a biologic or an intraperitoneal biologic would certainly be options, with the understanding that there'd be a relatively high rate of recurrence. A retrorectus placement of a biologic is certainly okay and is done quite often. However, there is increased cost and there may be an increased risk of seroma. And the retrorectus placement of absorbable synthetic mesh seems to be the best place for that material. I try to reserve a transversus abdominis release when the mesh is needed to be lateral to the semilunar line. For instance, if there's been a lateral hernia component to the hernia or an ostomy. And then I use the external oblique release, sparing as many perforators when relief of tension is needed on the anterior rectus sheath, as I believe that's where the majority of the strength of these repairs comes from. So again, I want to thank SAGES for the opportunity to present today, and thank you for listening.